Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Samuel Klempner from Massachusetts General Hospital and the Dana-Farber Harvard Cancer Center in Boston, and Dr. Gregory Botta from the Moores Cancer Center at UC San Diego Health. They will be discussing the rationale supporting Claudin 18.2 as a new therapeutic target for the treatment of gastric and gastroesophageal cancers, along with clinical considerations related to emerging Claudin 18.2 targeting therapies currently in development. This episode is part of a larger educational program titled Claudin 18.2, a new target for precision care of gastric and gastroesophageal cancers. For more information on the experts, along with a link to the complete program and associated activities and resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hey, my name is Sam Klempner. I'm a GI medical oncologist at MGH in Boston, and we're here to discuss rationale for targeting of Claudin 18.2, and I'm joined by Dr. Botta, who I'll let introduce himself.
Thanks, Sam. I'm Greg Botta. I'm a gastrointestinal medical oncologist at the University of California, San Diego. And as Sam said, we're going to be talking a little bit about the Claudin family of proteins and their therapeutic uses. Just to get us started, Sam, I was hoping maybe you could allow our listeners to know a little bit more about what Claudins are and their normal function, maybe where they're found.
Yeah, it's a great question and a good place to start for any biomarker. Where is the normal expression? And so probably got to go back to first or second year of medical school to think about tight junctions and basement membranes and et cetera. But all luminal organs have a luminal epithelium that has a basement membrane that's really important to protect things from inside the gut to leaking into the walls of the gut. And Claudin 18.2 is part of a family of tight junction proteins. There's another Claudin 18.1. And mainly Claudin 18.2 functions to regulate hydrogen and sodium ion exchange. It's kind of interesting. If you knock out Claudin 18.2 in a mouse, the mouse develops normally, except they develop atrophic gastritis from chronic inflammation, presumably from the acidic hydrogen ion leakage that's missing because of the Claudin 18.2 absence. So it's really a barrier function, tight junction protein in its normal state.
Yeah, and I think that's something that our listeners need to be aware of, because as we talk about targeting it, we always need to think about what are the side effects of it. And knowing what its normal functional state is allows us to understand what those potential toxicities will be. Now, as far as the gastric cancer and gastric mucosa are concerned, do you know where it's actually located, within which pockets of cells?
Yeah, it's interesting, as all these gastric cancers start off, of course, as normal gastric lining. And during the tumorigenesis process, Claudin is preserved in many patients, but it's actually reoriented. So normally it sits along the basolateral aspects of the cells near the basement membrane. But during the process of tumorigenesis and ultimately in the established cancers, the Claudin is repolarized and it's now more exposed on the epithelial, the more luminal side of the cell in tumors, which of course is attractive when thinking about targeting.
No, it's very true. I think that when I was first learning about Claudins, I was saying, well, it's really good to have a lineage-specific monoclonal antibody or CAR T cell to target something, obviously, that has very low off-target effects. Because obviously in solid tumors, finding lineage-specific, very similar to maybe B cells and CD20 is not always easy. And by showing that the Claudin 18.2 expression is on that normal gastric, but also the cancer, but that it's not in the stem cell component, I thought was really interesting, because as that stomach maybe turns over every couple of days with the stem cells, we're not depleting them, we're just depleting the pathologic and the differentiated states of the stomach. So I think that really reduces a lot of the toxicity.
Yeah, I think it's a very interesting point. People have done surveys broadly of Claudin 18.2 expression across normal tissues and malignant tumors, and obviously gastric is one of the highest hits, but also pancreas, some lung, and then rarely across other tumor types. And as you said, the normal expression pattern being relatively restrictive is an attractive feature. We should move on to a little bit more about this biomarker in cancer and how it's maybe different from some of the biomarkers that many of our listeners are accustomed to. So tell me a little bit about Claudin 18.2 and how you think about it differently than maybe HER2 and the routine testing that a lot of listeners are getting, next generation sequencing. Are they going to be able to find Claudin 18.2 in that kind of testing?
Yeah, this is a key point. Right now, Claudin 18.2 is evaluated by IHC, and the IHC cutoff is different between different studies. Some studies have looked at kind of 2+, out of 1+, 2+, 3+, looking at 2+ in greater than 40% of cells. Others have looked at 2+ in greater than 60 or 70% of cells. What we do know is that the expression of moderate to high 2+ or so in 40 to 70% of cells is really the key area of the IHC. We do know that there is a good correlation between the IHC patterns of the primary tumor and of the metastases as well. So generally, if a patient might have a biopsy specimen from the primary tumor or maybe an oligometastatic area or even a lymph node, that there is pretty good correlation between those to get that IHC back. Now, when we look at it versus HER2 and the amplification of it, with HER2, we're always looking at IHC staining, as you're aware, in FISH. And that all comes obviously from the TOGA study. Honestly, at the end of the day, in terms of Claudin expression, I do believe that one day we'll be able to correlate the IHC with gene expression by NGS. We do that with ERB2 and HER2 disease and looking at maybe a tumor cell-free DNA or next-generation sequencing evaluation of the bloodstream. I don't think that Claudin 18.2 is there right now. We're still doing a lot of evaluation with IHC. But I do think that in the future, acknowledging what you said earlier, Claudin 18.2 and 18.1 and different transcripts and exon splicing, we are going to be able to pull that out in the future. And we do know that, at least by RT-PCR, that Claudin expression in the stomach is highly upregulated in cancer, as it is in some of the other GI cancers, such as pancreas cancer as well. So I do believe that at one point NGS will be used, but right now we're restricted to the paraffin embedded IHC evaluation.
Yeah, I think IHC is something many pathologists and many clinicians are familiar with interpreting, and in some ways it's simple. There's a lot of biology still to be learned, but it's nice to have a biomarker that is potentially something that we can get our heads around, assuming this comes to the clinic in the future. Like many of our biomarkers, oftentimes they can identify certain biologic behaviors. Our MSI patients tend to be more favorable prognosis, respond to IO, whereas some other alterations like MET amplification are associated with just aggressive biology. Do we know much about Claudin 18.2 as a biologic subgroup? Do these people do better or worse, indifferent? Tell me a little bit about the sort of prognostic implications.
Yeah, so it's interesting about Claudin 18.2. I would say first is the type of tumors that it's found in. Usually found in these diffuse, more signet ring-like tumors. It's also found in adenocarcinomas over squamous, and it's found in more mucinous over serous tumors. And all of that's important because generally those types of tumors don't have a very good outcome on them to begin with. Now, there's been a variety of different studies looking at the prognostic implication of Claudin 18.2. And not only have there been single studies looking at patients with gastric cancer and GE junction cancers, but also large meta-analyses. And there was one recently in 2021 where they're looking at about 6 different studies. And they didn't find any correlation between Claudin 18.2 in T stage, N stage, M stage, or even overall survival. So at the end of the day, Claudin 18.2 being upregulated or increased amplification on tumors is a very good target, but having it particularly didn't really correlate with specific prognostic outcomes. That being said, I personally have seen it on a lot of highly aggressive malignancies, the diffuse signet ring subtypes. So if anything, it might be a little bit worse off. When we look at the study outcomes that are coming out, though, you can feel confident that those outcomes are indeed because of targeting Claudin 18.2 and not necessarily confounded by the fact that these patients are just doing better based on the fact that they have that high expression.
Yeah, that's my takeaway from Spotlight data and the retrospective cohorts is that it doesn't appear to have a strong independent prognostic value, which in some ways helps you feel like the control arm is performing in context with other modern phase 3s.
I think that when these studies come out, we had touched a little bit about it. How should you evaluate your patient for the use of a Claudin 18.2 study? What expression levels are you looking at? What are you biopsying? What are you saying off for analysis? Who's analyzing it? Maybe you could talk a little bit about what your clinical practice is.
Yeah, you raise a lot of really important things. And certainly we have a couple data sets with some Claudin targeting agents using different expression cutoffs. And consistent with some other biomarkers and targets like HER2 and other receptor tyrosine kinases, it does seem that there is a relationship between activity and level of expression. And if you look back at the old FAST data, you'll see the response rates and the outcomes were the best in patients with the highest expression. And that's why the Spotlight trial used a higher cutoff of 75% of tumor cells. And that's the data we have. Certainly, if we improve upon drugs and novel agents, we may be able to lower the cutoff or expand the group of patients who may benefit. What we've seen from the published series is that it appears to be relatively preserved expression. So like you mentioned, if you biopsy a MET or biopsy a primary tumor, if you look back at a non-metastatic archival sample compared to a later development of a metastatic, the concordance rates for Claudin seem to be very high. And that may be because we're just marking tumor cells. The optimal cutoff is, of course, something that remains to be determined. We only have phase 3 data for one cutoff at this point, and we'll see a lot of data to come. I think that there's going to be a lot of interesting work to be done, but at this time, if you find it on a biopsy, whether it's an older sample or a newer sample, I think you can feel relatively confident that that's real. I do think that all of us try to use the most recent sample anytime we're making clinical decisions. And so if you can be tested from a most contemporaneous sample, that's the preference. But if you don't and you have to act on an old sample, then I think that that would be a very reasonable thing to consider for implementation. I think that brings us to an important topic about sort of where to go from here for Claudin 18.2. We talked a lot about sort of the biomarker itself, and you mentioned briefly that this is a relatively tumor-restricted antigen. So tell us a little bit about the other strategies that are in development for leveraging that biology.
Yeah, of course. As soon as we, as oncologists, find a new target, we say, all right, well, let's start throwing all of our tools in the kitchen at it. And I think that you're starting to see the antibodies first come out, things like zolbetuximab. And as you mentioned, from the original mono study looking at zolbetuximab alone in gastric and GE tumors to the FAST study looking at EOX with zolbetuximab, and then all the way to Spotlight now with FOLFOX and zolbetuximab. What we're seeing is that there is response with the antibody alone, but we're also seeing that in combination with chemotherapy, it's well tolerated, and that we're starting to get increases in progression-free survival and overall survival that are of significance. And importantly, too, it was very interesting, and I don't know what to make of it right now, but it looks like, at least in the Spotlight data, the survival curves are really separating a little bit late. So I'm wondering if there's some type of change in the microenvironment that's going on with the use of zolbetuximab, similar to maybe what we saw with immunotherapy. And regardless, I think the side effect profiles of them are well tolerated. We do and should expect there to be a little bit of GI upset in these patients to begin with. And the fact that zolbetuximab or any type of Claudin 18.2 antibody is targeting the normal gastric mucosa as well, that may occur. Now, I think that some of the other ones that are in development now, and if you look, probably there's 20 plus different programs targeting Claudin 18.2 in development. Some are looking at ADCs with MMAE. Some are looking at bispecific antibodies with CD3. And then others are looking at CAR T cells as well. And of course, everyone has their favorite update or change to the molecule, the ADC or the CAR T itself. But at the end of the day, the big thing that's going to separate all of these are the specificity of targeting with low side effects in patients who have previously been heavily pretreated and with a lot of comorbidities. And I think that that's really the hurdle that needs to be jumped in these patients. We know as GI oncologists that these patients are sick, they're not eating, they're cachectic, and a lot of the side effects from a lot of these therapies are really what's going to make or break their use. And I think that at least in the antibodies, we're starting to see that they can be safely used in these patients even after first-line therapy. And truthfully, even CAR T cells are being evaluated tolerated in patients after multiple lines of therapy and are able to get them through. Now, of course, that takes a huge team behind you to get a CAR T program off the ground versus antibodies alone in maybe an outpatient infusion center. So there's going to have to really be some differences in response rates and PFS and OS for the CAR T to take hold. But I do believe that that's coming down the pipeline.
Yeah, I think this is fantastic. It's always our job to balance quality of life and quantity of life, as you mentioned. Well, look, it's been great to talk, as always, and I think this is going to be part of a much larger program to dive into some of the clinical aspects you mentioned. Always great to talk to you, and hopefully this was beneficial for the listeners.
Thank you very much, Dr. Klempner and Dr. Botta, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Claudin 18.2, a new target for precision care of gastric and gastroesophageal cancers, please click on the link in the show notes. As always, thanks for listening